Ecco. Buongiorno a tutti, benvenuti. Quest'anno il meeting annuale del Dipartimento di Medicina lo stiamo facendo qua. E lo stiamo facendo qua perché è il 25esimo di Bicocca e questo è un evento di quelli celebrativi del 25esimo di Bicocca. Quindi noi che siamo uno dei 14 dipartimenti, delocalizzato a Monza all'origine, 24 anni fa, non 25 anni fa, perché è nato quel piccolo campus dove lavoriamo, vicino al grande ospedale policlinico che è San Gerardo, e questa è stata l'idea iniziale, ci fa lavorare a Monza, ma banalità delle banalità, ma noi siamo uno dei dipartimenti, 14esimo, dell'Università Milano Bicocca, quindi la celebrazione del 25esimo anche per il Dipartimento di Medicina si è deciso di farla qua, di averla qua e di organizzarla qua, col nostro meeting annuale, che anche quest'anno è organizzato tantissimo, ecco, quindi io e pochi altri hanno solo aiutato i nostri più giovani assegnisti, ricercatori di tipo A, che hanno immaginato l'argomento, che hanno immaginato gli speakers, e quindi tutto il programma si è sviluppato grazie alla loro dedizione sia di pensiero ma anche pratica, ecco, perché c'è stata una parte pratica molto importante. Questo mostra la nostra attenzione ai più giovani, perché si vuole e ci stiamo dedicando. Da che sono direttore a ottobre 2 anni, ecco, abbiamo fatto varie attività con gli assegnisti, con queste figure a tempo determinato e dall'anno scorso anche affidare a loro, che così possono interagire, esprimersi, l'organizzazione del meeting annuale, e anche quest'anno. Quest'anno l'argomento è le sfide della medicina, molto ampio. Nel pomeriggio abbiamo dedicato tutte le presentazioni a una delle sfide della medicina, che è la medicina evoluzionistica, mentre la mattina avremo le presentazioni dei nostri giovani sulle sfide della medicina nel loro ambito, quindi loro si dedicano a alcune frontiere e ci presenteranno le loro attività. Avremo 3 presentazioni prima di un break a metà della mattina, che sono più di argomenti di base, e 3 presentazioni loro nella seconda metà della mattina su argomenti più clinici. La moderazione, la discussione la faranno loro, con, ci auguriamo, il coinvolgimento di tanti di noi, di voi. Alla fine della mattina abbiamo la presentazione dei vincitori del concorso fotografico, a cui tanti di voi hanno partecipato, quindi tanti hanno mandato le loro fotografie. Il tema era la salute, quindi molto ampio, e l'originalità delle foto è stata veramente interessante, quindi poi una giuria, ma poi Miloso ci gestirà questa parte perché ci si è dedicata moltissimo. Ecco, c'è stata una giuria che ha identificato le 3 migliori, prima, seconda e terza fotografia, e quindi avremo questo finale della mattinata. Poi, dopo il lunch, parte la parte dedicata alla medicina evoluzionistica con speakers esterni, uno di grande prestigio che è Randolph Nesse, è considerato il padre di questa nuova disciplina, viene dal Michigan, ieri abbiamo cenato insieme, sarà, sono sicuro, una bellissima lettura perché è molto vivace, è molto sveglio, e tanto da avere portato diciamo, un contributo importante nella sua carriera proprio nella medicina evoluzionistica. E altri speakers, questi italiani, che ciascuno leader e prestigioso nel suo settore. Quindi avremo un paleogenetista, un antropologo, paleontologo, storico della medicina, il tutto coordinato con una moderazione del nostro prorettore alla didattica, il professor Casiraghi, che è un biologo evoluzionista e quindi diciamo che è proprio il suo pane. Ecco, qui la discussione verterà più che impatto potrà avere nel presente e nel futuro nella medicina. Ecco, ma già da più anni questo pensiero evoluzionistico diciamo, è molto presente nelle scienze più di base e proprio Casiraghi è uno dei suoi, è il suo argomento. Alla fine ci sarà una, spero bellissima, contiamo bellissima, tavola rotonda dove tutti questi speaker di prestigio si esprimeranno insieme anche all'audience, e quindi tanta interazione, tante domande, tanta discussione. Quindi ci attende una giornata molto ricca anche di discussione e di coinvolgimento di ciascuno di voi. E quindi facciamo partire l'attività. Quindi chiamo i primi due moderatori, che sono sempre giovani, che poi introdurranno i singoli speakers della prima metà della mattina. Prego, venite, lasciamo a voi il lavoro della mattinata. Grazie a tutti.
Ringraziamo innanzitutto il direttore per darci l'opportunità di partecipare attivamente alla giornata del Dipartimento. Cominciamo quindi con le prime presentazioni della mattina dell'ambito preclinico e in particolare cominciamo con la dottoressa Mingardi, che è assegnista di ricerca. Olga, scusatemi, cambio di programma, con la dottoressa Olga Tarasiuk, che è assegnista di ricerca in anatomia umana presso il laboratorio del professor Cavaletti, e ci presenterà una presentazione intitolata Neuroinflammation as a Mechanism of Chemotherapy-Induced Peripheral Neurotoxicity.
Good morning, everyone. I would like to represent you my topic, which is neuroinflammation as the mechanism of chemotherapy-induced peripheral neurotoxicity. Chemotherapy-induced peripheral neurotoxicity is the severe nerve-damaging and dose-limiting side effect of antineoplastic drugs. It's characterized by the sensory, motor, and autonomic system dysfunction, and is characterized by such symptoms like pain, tingling, numbness, impaired function in the hands and feet. Since no effective treatment is available at this moment, the only option to prevent the severe damage of the nerve is the reduction or withdrawal of treatment. Even though the pain and sensory abnormalities in the hands and feet can remain persistent in the patients after the cessation of chemotherapies. Chemotherapeutic drugs are represented by the different groups. They can be either the platinum-based antineoplastics, vincalcaloids, epochilones, taxanes, proteasome inhibitors, and immunomodulatory drugs. The most toxic of them are considered to be the platinum-based drugs, with the prevalence between 70 and 100% of CIPN development, as well taxanes with the prevalence between 11 and 87% of CIPN development. Almost all cancers nowadays are still treated with the chemotherapy. 50% of the patients younger than 50 years old, which are diagnosed with the cancer, are treated with the chemotherapy. That's why, to understand how the chemotherapy develops neuropathy is the crucial moment in order to improve the patient's life and avoid reduction or withdrawal of the treatment. However, chemotherapeutic agents have quite different mechanism of its antineoplastic effects. For example, platinum drugs are binding to the DNA, creating the platinum adducts and inhibit DNA replication and RNA transcription. Immunomodulatory drugs, for example, are blocking the TNF-alpha and NF-kappa beta, as well as having some blocking effect of angiogenesis. The taxanes are binding to microtubules and prevent the polymerization, which inhibit the mitosis in the dividing cells. Epotilones as well are binding to tubulin and prevent the polymerization of the tubulins. The vincalcaloids are having the opposite effect. They prevent the polymerization of the microtubules. The proteasome inhibitors are binding to the 26S subunit of proteasome and inhibit degradation of various pro-apoptotic factors. Over decades, have been identified 5 main mechanisms how chemotherapeutic agents develop neuropathies. They can rather directly target mitochondria and producing oxidative stress. As well, they can lead to the DNA damage. They can impair the function of ion channels, trigger immunological reaction and activation of glial cells in the neuronal tissues, as well disrupting of microtubules. The cascade of events can be starting with the dysfunction of mitochondrial integrity that influence the calcium influx. Disruption of calcium homeostasis can influence the neurotransmitter release, which can activate the astrocyte and cytokine release. The activated cytokines can activate glial cells and trigger neuroinflammation in the tissue, which further again comes back that neuroinflammation can damage mitochondria and disrupt the axonal transport. So as for all diseases, the 2 main questions are always how to diagnose it as soon as possible and how to develop the proper treatment. Unfortunately, for chemotherapy-induced neuropathy, these 2 questions remain quite limiting factors. Still nowadays, there is no standard measurements of CIPN. It's still based on the objective measurements such as nerve conductive studies and total neuropathy score measurements, which can be quite invasive and still have a lot of biases due to subjective responses of the patients. However, if we will be able to identify the proper biomarkers for this disease, it will be much easier to identify disease, to stratify the patients, as well to have insights in the disease progression and pathogenesis, and as well to develop a proper treatment. In the literature, some proteins are considered to be some biomarkers, however, none of them are completely standardized and applied in the medicine. For example, neurofilament light chains is the protein which is released in the axonal damage, as well brain-derived neurotrophic factor and nerve growth factors, which are proteins of neuronal survival, osteopontin and some other inflammatory markers, as well as some microRNAs, proteomics, and metabolomics as results of the protein signatures. The treatment of CIPN is not completely existing. There are some treatments which can have some neuroprotective effects. For example, some of them are oriented on the reduction of mitochondrial dysfunction and oxidative stress. Either some antioxidants as well. Some other treatments which are targeting ion channels, for example, blocking sodium channels, as well as some therapies based on neurotransmitters, for example, those which are blocking serotonin and norepinephrine, as well as some anti-inflammatory therapies that can block monocytes. So as we have seen, hemotherapy-induced peripheral neuropathy is the disease that involves a lot of different cellular processes that are happening contemporary. For example, such events like mitochondrial dysfunction, microtubules damage, oxidative stress, reduce of ITP, impairment of ion channel canals, activation of immunological reactions and astrocytes that are leading all to the tissue damage, such as axon degeneration, fibers loss, demyelination, apoptosis, and cell death. Of course, the degeneration of the tissue trigger neuroinflammation and development of peripheral neuropathy. That's why we believe to concentrate our attention on neuroinflammation will be an important point in order to identify clearer biomarkers as well as development of some treatments. Neuroinflammation is innate immune system process triggered by the events like injury, infection, toxins, and neurodegenerative diseases. It can be the local inflammation, which is characterized by the activation of glial cells and secretion of pro-inflammatory mediators, as well as the systemic inflammation, where happened the infiltration of the immune cells in the tissue. The local inflammation is characterized by alteration of Schwann cells and glial cells in the DRG, as well as astrocytes in the spinal cord. It can lead to the decrease in the protection of fibers and defects in the propagation of action potential. The glial cells can also secrete pro-inflammatory cytokines, for example, like IL-6 and chemokines. Those are activating the macrophages in the tissue. The macrophages in the next step can activate inflammasome in the tissue or intracellular loss and secretion of other inflammatory mediators. The local and systemic inflammation can cause the neuropathy pain. Inflammasome is the crucial component of innate immune system identified not so long time ago, which can be present as well as in immune cells as well as not in the immune cells. It's composed of three main proteins such as NLRP3, apoptosis-associated spic-line protein, and inflammatory caspase 1. Assembly of inflammasome triggers the paroptosis, which is cell death, distinct from apoptosis by activation of the other sets of caspases. For the activation of inflammasome are necessary two signals. In the first signal, the pattern recognition receptor activates the inflammatory pathway and secretion of pro-caspase 1 and pro-EL1 beta protein. In the second signal, cells that censor the damage activate NLRP3. When inflammasome is assembled, it can release EL-beta-1 mediator of fever, pain, and neuroinflammation. In our project, we wanted to concentrate our attention and compare the different chemotherapeutics drugs in one single animal model to identify four main mechanisms of chemotherapy induces peripheral neuropathy development, such as impaired axonal transport and tubulin damage, neuroinflammation, calcium homeostasis, as well as mitochondrial toxicity. We started with concentrating our attention on neuroinflammation. So we treated the male rats with the paclitaxel, oxaliplatin, and bortezomib for 4, 6, and 8 weeks long, respectively. We collected the neuronal tissue such as DRG, spinal cord, sciatic nerve, and the caudal nerve at the 3 different time points, 24 hours, in the middle of treatment, and at the end of treatment. We analyzed expression of 3 proteins, NLRP3, which is the marker for inflammasome activation, EL6, pro-inflammatory interleukin, and CCL2. We were able to see that the paclitaxel is able to activate, Okay, so paclitaxel is able to activate inflammasome activation. As well, the increase of CCL2 was significant, and as well, the EL6 was significantly increased in the tissue. However, when we analyzed the tissues from the oxaliplatin, we were not able to see any single change in our markers. Bortezomib showed only increase in the CCL2 cytokine, but not the other markers. This data was confirmed by immunohistochemical staining, where we were able to see that the caudal nerve showed the increase of macrophages infiltration at the end of treatment in the distal part of the caudal nerve. As well, here in the image, we see that the distal part showed quite significant degeneration of the fibers and infiltrates of macrophages. Oxaliplatin, of course, didn't show any infiltration of macrophages. The data was confirmed as well by the neurophysiological and dynamic tests, where we were able to see that the paclitaxel clearly induced allodynia in the rats as well reduction of the potential amplitude and the reduction of the nerve conducting velocity. Oxaliplatin didn't show the same result. It only showed the significant diminution of the potential amplitude of the nerve. Bortezomib showed quite similar results to paclitaxel. It showed the infiltrates of the macrophages, as well allodynia, as well as the reduction in the nerve conduction velocity and potential amplitude. And if you remember, even by showing the similar results in this test, we were not having the same expression of the markers. For example, inflammasome was not activated in the bortezomib. So I would like to conclude that with our data, we analyzed 3 different drugs, and all 3 of them showed us quite different pattern of neuropathy development. It was only the paclitaxel that showed us the activation of inflammasome in the tissue, especially in the distal part in the caudal nerve. This data confirm us once again that neuropathy is the complex interplay where all the mechanisms need to be analyzed simultaneously and be looked at from the different aspects. On this, I would like to thank you for your attention. As well, I would like to thank our professor Guido Cavaletti, my direct supervisor Cristina Meregalli, Professor Foti for collaborating with us, and all the researchers of the ENO group for their support and participation in the project. Thank you very much.
Grazie Olga per la presentazione molto interessante. Ci sono domande da parte del pubblico? Qualche curiosità? Prego. Arrivano i nostri balletti.
Bene. Bene, bella presentazione. I macrofagi, abbiamo sottoclassi di macrofagi, M1, M2. Avete dei dati? Perché hanno funzioni anche, direi, forse diametralmente opposte. O li guardate? Avete dei dati su questo?
No, non credo che abbiamo guardato in generale dei macrofagi senza identificare 2 diversi sottotipi.
Qualche altra domanda? Chiedo io una curiosità. Ho visto che i vari trattamenti sono stati fatti a dosi differenti, a tempi differenti. Sulla base di cosa è stata fatta questa scelta?
Sono dosi differenti e anche tempistiche differenti perché sono i modelli standardizzati dove l'animale alla fine sviluppa neuropatia. Questo per noi è interessante, che tutti gli animali hanno neuropatia alla fine. Sì, sono modelli che usiamo già da tantissimi anni nel nostro laboratorio e sappiamo che a questa tempistica, a questa dose, tot trattamenti per settimana, animale sviluppa neuropatia.
Ho capito. Ho visto anche che hanno una differenza nella composizione della parte del nervo caudale e distale. Da cosa è dovuta questa differente degradazione?
Questo è qualcosa molto tipico per neuropathy, which is qualcosa che si chiama in inglese dying back effect, quando progressione della malattia comincia dalle parti distali del nerve e prosegue poi verso parte prossimale. Probabilmente questo effetto è dovuto al fatto che nelle parti distali c'è meno supply dell'energia, dell'ossigeno nei tessuti e poi ovviamente come il nervo prosegue sua degradazione, prosegue verso parte prossimale. Così anche nei pazienti tutti i sintomi si cominciano con dite o anche estremità o anche sui piedi.
Ok, grazie. Se non ci sono altre domande, ecco. Ti avevo visto.
Grazie mille, sempre molto interessante. No, Ho una domanda relativamente allo stato patologico. Voi giustamente in questi studi state usando animali di controllo trattati con lo stesso protocollo utilizzato poi per la terapia invece in caso di tumore, approccio che capisco e condivido. La mia domanda però è se pensi o pensate che l'aspetto di neuropatia periferica possa essere diverso o uguale in caso di tumore, cioè il tumore potrebbe aggravare, avere un ruolo nel modificare questi processi, o pensate che sia invece indipendente perché non lo so?
Sì, cioè, i nostri animali non hanno tumore quando noi induciamo neuropatia. Noi studiamo giusto la malattia senza indurre lo sviluppo del tumore nell'animale, però ovviamente assolutamente quando si muove sul modello paziente probabilmente lì l'effetto di presenza del tumore può dare un certo effetto. Sì, magari possiamo anche valutare qualcosa del genere quando prendiamo un animale, induciamo il tumore e poi anche neuropatie, diciamo.
Va bene, se non c'è altro passiamo la parola alla seconda speaker del mattino, Jessica Mingardi. Jessica è assegnista di ricerca presso il laboratorio di farmacologia coordinato dalla professoressa Laura Musazzi e oggi ci presenta i suoi risultati volti a valutare gli effetti della chetamina in un modello animale di depressione. Prego.
Okay, so thank you, and I'm very happy to be here today and have the opportunity to share with you our ongoing project. Okay, so stress is a physiological response of our body that we activate every time that we have to face stressful events. That could be major life events, traumatic events, but also everyday stressors, like, for example, standing here in front of you and talking. And usually, our body activates a series of responses that are with the intent to cope with these stressful events. And this is what happens in the majority of us that we can call resilience. However, there are some individuals, and luckily they are a small number of us, that in some occasions fail in activating these coping strategies. And they become vulnerable. And these conditions favor the onset then of chronic conditions, chronic disorders, including neuropsychiatric disorders such as major depressive disorders. Depression is a highly heterogeneous pathology characterized by both mental and physical alterations, multifactorial, and two main symptoms required also for the diagnosis of depression are a persistent low mood and the lack of pleasure, that is defined as anhedonia. The problem with depression is that so far we don't know why we do develop depression. So it is extremely important to study this pathology, and to do that, to use a preclinical model, and in particular animal model of depression, are fundamental. And most of them are based on the exposure of the animals to stressors. Regarding the treatment of depression, patients are now treated with the so-called traditional antidepressants that are effective in most of them, but they require a chronic treatment that require also a long period, 3-4 weeks, to have the onset of the therapeutic effect. They have many side effects, and importantly, in approximately 1/3 of the patients, they lack of efficacy. And this is a huge problem because when a patient starts to fail more and more treatments, they develop a condition that is known as treatment-resistant depression. And this is even harder to treat. So the research has tried to address these issues, and in the last 20 years, the attention has been focused mainly on this molecule, which is ketamine. Ketamine was already used in clinics as a dissociative anesthetic, is also known as a drug of abuse, but when ketamine is used at subanesthetic levels, it exerts an antidepressant effect that is rapid, so in 1-2 hours, and long-lasting, up to weeks. So this was striking, and it was extremely important, and led in 2019 to the approval of the intranasal esketamine for the treatment of TRD patients. However, ketamine has an abuse potential. And moreover, some of the patients do not respond even to ketamine. So ketamine is not an ideal drug so far, but still we can use it to model and to study the mechanisms behind the rapid antidepressant effect. And this is what we do in the lab. So we use the chronic mild stress animal model of depressions in a male rats to study the molecular mechanisms behind the response or non-response to the fast antidepressant ketamine. And our protocol basically lasts 5 weeks, during which the animals are exposed to stressors, and these induce a depressive-like phenotype in the animals. And every week we test the animals for their depressive-like phenotypes, and 24 hours before sacrificing the animals, we treated them with a single subanesthetic dose of ketamine to test the antidepressant effect of this drug. So during these 5 weeks, the animals are exposed to different types of stressors that must be characterized by the fact to be chronic, unpredictable, and unavoidable. And this can include physical stressors, like depriving the animal of the food, the water, or environmental stressor, changing the condition of the cages, or inverting the light-dark cycle, but also social stressors, overcrowding and isolation. And these stressors induce a depressive-like phenotype in the animals that we measure by using a test, which is called Sacros preference test, and specifically measure the anhedonia, the lack of pleasures, and is based on the natural preference of the animals in drinking and preferring sweets. So we measure basically the preference of the animals in drinking a sweet solution, a sucrose solution, over their total consumption of water. And what we found is that through the 5 weeks, the control didn't change their preference, while if you look at the red, so the red dot, the stressed animals, starting from 2 weeks after CMS, they develop an anhedonic-like phenotype. And this is maintained until the end of the protocol. But if we look better at the stressed animals, we can see that not all the animals have the same behaviors. And if we set a cutoff, the 70% of the sucrose preference, we can then distinguish 2 separate groups of animals. The resilient animals in blue, without changes in the sucrose preference, from the vulnerable animals with a decrease in the sucrose preference, so an anhedonic, a real anhedonic phenotype. And as you remember, we treated them with ketamine, and we observed that the animal treated with ketamine completely rescued the anhedonic phenotype in 24 hours. But again, if we look better at this group of animals and set again a threshold at the 70%, we can see that approximately 1/3 of them do not respond to ketamine, so they do not recover from the anhedonic phenotype. So that's why in our further experiment, we use 5 experimental groups, so the control animals, the resilient, the vulnerable, then the vulnerable animals treated with ketamine and responders, and the vulnerable animals treated with ketamine but that do not respond. And what we are doing in these studies is to perform a transcriptomic analysis of the hippocampus of these rats to find changes in gene expressions. So at sacrifice, we collected the hippocampus of the animals, extract the RNA, and perform RNA sequencing. And we found that there are several genes differentially expressed in our experimental model, and not so simple way to visualize this is by using this graph, which is called upset plot, where you basically can see the number of genes that are differentially expressed in the comparison between the experimental groups. And what we can say, looking at this, is that both stress and ketamine treatment induce specific changes at transcriptomic level. But we want to know the pathway, and in particular the biological process in which these genes are involved. So we performed a bioinformatic analysis called gene set enrichment analysis. And I reported here only a few of the comparisons. For example, between vulnerable and resilient animals. And just to simplify, the blue columns on the right means that there is an enrichment in the pathway in which the genes are involved, while the orange means that less enrichment. So comparing vulnerable and resilient, the vulnerable animal seems to have an enrichment in pathway of related to extracellular structure organization and the cardiovascular system development, while less enrichment in synaptic-related pathway. We also observed that the response to ketamine is associated with an enrichment of pathway linked to synaptic signaling, cellular morphogenesis, and also response to ions. When looking at the comparison instead with the non-responders, we see that these animals has an increased enrichment in pathway related to epigenetic modification, like histone methylation, while less enrichment in pathway related to immune activations and cardiovascular system development. So when comparing directly the non-responders and the responders animals, we can see that the non-response is associated with less enrichment in pathway of dendrite development, synaptic signaling. So again, synaptic functions. So I'd like to conclude saying that the chronic mild stress animal model is a valid model to study the mechanism of response, non-response to ketamine. That our transcriptomic analysis performed on the hippocampus of these animals revealed transcriptomic changes induced by both stress and ketamine treatment. That there are specific signatures of stress vulnerability resilience and ketamine response. And looking at the biological pathways involved, the mostly affected were the ones related to synaptic organizations and function. And what we are doing now and want to do in the future is to try to integrate these results with the results coming from other omic approach, like proteomic and DNA methylomic experiments, to try to have clearer pictures and understand the mechanisms of fast antidepressant response. And I'd like to thank all the people that are participating in this project, all the neuropsychopharmacology lab, headed by Professor Laura Musazzi, our collaborator at the University of Brescia, our funding, and all of you for the attention. Thank you.
Grazie Jessica per la presentazione. Ci sono domande da parte dell'audience? Fra? No.
Thank you for your presentation. One curiosity. SSRI or classical antidepressant have a long time before have an effect. Have you some data, transcriptomic data in your model, or will you plan to do it? Because this is really important to understand the fast versus the long time to reach an efficacy.
Yeah, thank you for the question. So this is extremely interesting. We are not right now planning on doing that, so we don't have data about traditional antidepressant transcriptomic effect. Of course, it would be interesting. And yes, because yeah, we want to understand exactly the rapid, which are the mechanisms that are underlying this. So for example, maybe we are more interested right now in also other types of molecules like psychedelics that have in common with ketamine the fact to be rapid. So this is the direction that we want to take, but it could be interesting to address this.
Allora, molto interessante. Io ho visto nella tua analisi bioinformatica che spesso citi il sistema cardiovascolare diciamo, negli animali che rispondono meno alla chetamina. Avete un'idea di che cosa sia il collegamento tra la risposta alla chetamina e quindi diciamo, un comportamento antidepressivo e diciamo, il sistema cardiovascolare?
Okay, so we haven't dig into that right now, but for sure is extremely interesting because, for example, there are already studies not about ketamine but about depression, telling the involvement of the vascular systems. For example, also for the blood-brain barriers involvement. So this could be something related to that, and it's worth investigating. It could be that ketamine can have some effect at that levels.
Thanks. Have you an idea if which is the role of the cannabinoid receptor CB1 in ketamine effect, and if these interactions should also explain the resistance that you get when you develop your model?
Okay, thank you. So I have to be honest, I'm not an expert on that field. I know that there are many studies investigating the cannabinoid systems and antidepressants. I think it's something that we can look into, but yeah, so far it's, for example, coming from the bioinformatic analysis, it's not something that came up at the top of our pathways that we highlighted pathways, but maybe looking better we can understand something of this. We are not looking specifically at cannabinoid, so I cannot tell you precisely something.
You hear me? Yes. No, just I request you additional information about the transcriptomics analysis that you performed. Do you have already some data, because you know that can confirm the pathways that you have identified, because this is really relevant, because you know let's say in silico data analysis has a certain degree of uncertainty that needs really to be tested. So do you have any data about that?
Okay, so of course we have to, I mean, this is just the starting point. We have to perform and also maybe with the help of the integration of other omic approaches, it could be clearer. But what I can say is that, for example, the pathway that came like related to the synapse, so synaptic organization and function, it is something that we know is involved in ketamine effect. So coming from other preclinical studies that we have also performed, we know that one of the mechanisms of ketamine is to modulate plasticity at synaptic levels. And this is published from us and from many others. So this was particularly interesting and striking for us to find again this data. But I cannot speak about specific genes or specific, because this also wasn't something that we were looking at this point. We were trying to have a big pictures before. Yeah, this is just an idea based on also on the fact that, you know, as I said, considering depression, which is a highly heterogeneous, complex pathology, just looking at one gene, that is something that we did. But maybe now with these technologies, it's also good to have a broader picture. Then, of course, it would be helpful to confirm that also with other experiments, and this is something that we can and we will do in the future, but maybe when we have understood better this data.
Grazie, presentazione molto interessante, però io vorrei semplicemente chiedere una cosa, un'attenzione al modello. Lei ha scelto come modello dei ratti maschi, ma vorrei sapere qualcosa di più sul modello, nel senso che avevano caratteristiche comuni, un'età uguale, perché poi logicamente se sceglieva ratti femmine ci sarebbe stata un'implicazione differente, una risposta differente, anche se sappiamo che la depressione è un fenomeno, ahimè purtroppo, anche molto legato al mondo femminile, per una serie di motivazioni. Quindi una spiegazione in più sul modello mi farebbe piacere. Grazie.
Yes. So the rats that we use are at the same age, and they are also tested before. Maybe I didn't told that, but at the beginning, when we test with the sacrospressors, for example, they are tested also with the control before starting the stress. So we know that they are not different. So that what we see next is due to the treatment. But they are more or less the same. They are not like mice, so there is some more variability within the animals than with mice. But regarding the females, this is a limitations of our study. But it is also due to the fact that it is a complex model, is challenging, so it's difficult to repeat it and to do that with the females, because, as you said, you can introduce another variable, so estrous cycles, this stuff. Of course, this is something that at some point must be addressed, and maybe in the future we can think about that. So far, there are more studies investigating this. Maybe I think using animal models, stress-based animal models that are easier to perform. Maybe they are short, but maybe in the future it's something that we can consider.
Se non ci sono altre domande, ringrazio la dottoressa Mingardi e continuiamo con l'ultima presentazione dell'ambito preclinico della dottoressa Isabella Piga, che lavora nel laboratorio del professor Magni e ci presenta un lavoro intitolato Imaging Beyond Imaging, Beyond Imaging, Molecular Snapshot of Thyroid Cancer.
Good morning to everyone. So today we will imagine beyond imaging. So we will see, by the end of my presentation, you will have more clear how tissue imaging can foster thyroid nodule diagnosis. So my presentation will be divided in 4 sections. First, I will explain the challenging of thyroid nodule diagnosis, and then I will explain what is mass spectrometry imaging. Then we will see the adding value of molecular imaging in thyroid pathology. And finally, we will discuss together the impact of tissue imaging in the clinical pathology diagnosis, and we will see how it will advance precision medicine. But let's start from the beginning. So, thyroid is a butterfly-shaped endocrine organ which is located at the base of the neck, right in front of your trachea. And the most common endocrine disorder is the appearance of a thyroid nodule. The diagnosis of a thyroid nodule is based on fine needle aspiration biopsy, which is a minimally invasive approach in which a fine needle will be inserted directly into the nodule under echographic examination. Then the sample will be transferred onto a slide and will be evaluated based on its morphology under a microscope by a pathologist. So the diagnosis can be benign if the lesion is actually benign, can be malignant if in the sample there are malignant cells, but in some cases the pathologist is not able to give a clear-cut benign and malignant diagnosis. So the nodule will go under the indeterminate category. So in benign cases, the patients will go to a follow-up, so we'll have to repeat the fine needle aspiration, but in the case of malignant nodule, the patient will undergo total thyroidectomy, which of course have many consequences, so public health costs, surgical stress condition, and of course the need of a lifelong hormone therapy. But among 30% of thyroid nodules are actually diagnosed as indeterminate, which means that the patients will undergo diagnostic total thyroidectomy. But after the surgical removal, it has been observed that about 80% of those patients had actually a benign thyroid nodule, and only 20% were malignant, which means that they could have avoided the total thyroidectomy. So the total thyroidectomy was actually unnecessary. So it's clear that there is the need to assist the pathologist in the diagnosis of those indeterminate lesions. So keep in mind this first clinical problem, but let's go even further. Because among the indeterminate lesions, there are some thyroid lesions which actually keep their indeterminate status even after the thyroid removal at an histological state. And among those, we have the NIFT-P thyroid lesions, which are characterized by the presence of mutation in a gene which is called RAS, which will, of course, produce an abnormal RAS protein. While the majority of the NIFT-P are characterized by RAS mutation, inside of the NIFT-P category, we have a large number of questionable cases, which are, however, RAS wild type. But the morphology of NIFT-P lesions, independently from their RAS mutational status, are actually indistinguishable. So, the RAS mutational status alone is not a sufficient information to discriminate aggressive lesion from indolent one. And we need a way to help the pathologist in the follow-up of those lesions. So this is the second problem we want to focus. So basically, the pathologist in both cytological samples and histological samples can have issues in discriminating the morphology of those tissues. And here starts our job. So we decided to focus on the molecular proteomic characterization of those lesions and to correlate the molecular information with the morphological one. How? Using mass spectrometry imaging. But let's start step by step. Mass spectrometry is an analytical technique that, starting from a complex biological sample, can measure and separate molecules based on their molecular weight. And the output is a graph which is called the mass spectrum, in which we have thousands of signals, and each signal represents a molecule. So we have two kinds of information from that, which is the molecular weight of the molecules and the relative intensity. So what is mass spectrometry imaging? Now, I know we are close to a coffee break, but I would like you to think that the tissue is actually a pizza, okay? So the mass spectrometry imaging is a non-destructive technology. And now let's imagine that the topping in our pizza is actually a molecule. So mass spectrometry imaging will allow us to see the spatial localization of each molecule in our pizza so that we can choose the slice of pizza that we want. And let's imagine to go back. If we want to focus on a specific morphological area in our pizza, the technique will allow us also to select specific region of interest. So let's focus only on the region of interest that contain basil. And what kind of information we can get from that? We can immediately see that olive is never present close to the basil, but we only have mushrooms and salami. And this is a kind of information we can also have from protein in our tissue. What we can also do, we can remove the topping from our pizza, we can mix together everything, and then we can do a standard mass spectrometry analysis to identify the exact type of mushroom present in our pizza, the exact cultivar of the olive, and the exact salami, okay? Of course, as you can imagine, we love pizza, but we don't actually analyze pizza. We analyze tissue. So the technique works in this way. You have a slice of tissue, which will be transferred in a glass slide, and then we have a laser that will be rastered into the tissue and will release the protein molecules positively charged from the surface of the tissue. So each point in our tissue is a pixel, and each pixel will generate one single spectrum. And all of those single spectrum will be then averaged all together in one mass spectrum, which is the mass spectrum of all the tissue region. And each signal can give us the spatial localization of the molecules into the tissue. So as I said before, with the pizza example, we can then, after the imaging, we can extract the molecule, we can identify them, and then we can stain our tissue in order to co-registrate molecular information with the morphological one. So now, hopefully, you have clear what is mass spectrometry imaging and what it can be done with that. So now we'll see that the adding value, the innovative role of mass spectrometry imaging in cytopathology is that the technique is a non-destructive technique that allows us to integrate the molecular information with the cytological one so that we can extract the molecular signature of benign lesion and the molecular signature of a malignant lesion so that we can classify the indeterminate lesion based on their molecular profile. So the work started actually in 2017, and it was founded by an IARC grant, won by Professor Pagni. And in the first 2 years, we have focused in method improvements. So the first problem in our sample was the hemoglobin contamination. So the sample is collected right from the nodule of the patient, so it was rich in blood. And the problem was that in our mass spectra, all the signals were basically hemoglobin. So the hemoglobin was suppressing all the other molecular information. So what we did was to optimize the method, and to do that, we have used an approach which is already available in the pathological unit that's called team prep system. With a team prep system, we could filter the cytological sample, remove the red blood cells, and then we could reduce the area of analysis from to a monolayer of cells of only 2 centimeters of diameter. So basically, with this approach, we could decrease the amount of hemoglobin and increase the signals coming from the sample. But we decided to not stop here. So we had a protocol now that was robust and sensitive, but we further optimized it. So using a cytocentrifugation approach, we have reduced the area of analysis from 2 centimeters to only 6 millimeters of diameter, so that we could place in our slide up to 8 samples, and not only 1. So at the end, we tested also the reproducibility of the approach and the stability from both a proteomic and morphological point of view. So at the end, we had a method that was also reproducible and stable. So we started with 1 sample per slide, with a time of analysis that was going from 10 hours to have one slide with 8 samples on it, and for each sample we could analyze 1 sample in only 4 hours. So at the end, the method was also fast. So in 2018, we finally reached our goal, and we had our improved method. That method was then applied to a biggest cohort, of course, of samples. So in a first study, we have demonstrated the feasibility of mass spectrometry imaging approach to discriminate benign lesion from malignant lesions using cytological samples. Basically, we used a statistical approach in which each pixel in our analysis was colored in green if the patient was benign, or in red if the patient was malignant. And then we went even further because we have tried to subtype benign lesion. So in both Hashimoto thyroiditis, which is a benign lesion, and in the case of NIFT-P lesions, which are pre-malignant lesions. And then we went even further, and finally, in 2022, we have tested our mass spectrometry imaging statistical model, and we saw that it can correctly classify indeterminate cases when the cytological sample was actually cellularly adequate. And in this case, we have also proposed a novel workflow in which the multi-mass spectrometry imaging approach will be inserted in the clinical routine for the classification of those indeterminate lesions. So now we have seen which is the impact of mass spectrometry imaging in cytological samples. But let's move forward to the second point. So mass spectrometry imaging can be also used in the case of tissue pathology. So in this study, the objective was to characterize NIFT-P lesions using spatial proteomics, and this work was done in collaboration with the European Institute of Oncology that performed the NGS analysis for the genomic characterization of the lesions, so that we knew which lesions were actually RAS mutated and which lesions were actually RAS wild type. So using the mass spectrometry imaging approach with a completely untargeted approach, so focusing our attention on all the spectra and all the signals, we saw that the approach could segment the tissue, is just an example, of course, distinguish in red the area which are the surrounding tissue, the not nodular parenchyma, from the nodular region. And if we go even further in the nodular region, we saw that the mass spectrometry imaging could highlight correctly, as it was previously annotated by the pathologist, the NIFT-P nodular region in red and the hyperplastic nodular region in blue. But with the untargeted approach, we could get really a lot of information about the RAS mutational status. That was our first goal. So we decided to use an original approach, which is a targeted approach, starting from an untargeted proteomic approach. So what we have done was to look to the protein interacting with the RAS. Using the intact database, we have extracted the information about the protein interacting with the RAS protein, and then we have merged that information with the list of identified proteins in our samples and with the mass spectrometry imaging dataset. So we have found that in our mass spectrometry imaging dataset, there were 4 proteins that were actually RAS protein interactors, and focusing our analysis and our segmentation only on those 4 proteins, we could observe that. So in white, you can see the NIFT-P annotated nodule. So using only those 4 proteins, we could actually see the differences and extract the information between the differences of NIFT-P RAS mutated and correctly the NIFT-P RAS wild type. If we look, however, at the all tissue section, we could also have another kind of information, because the method in this way wasn't only able to segment the NIFT-P nodule, distinguishing based on the RAS mutational status, but we can also see that the RAS wild type is actually very similar to the hyperplastic nodule. So they were clustering under the same knot. And this suggests us that the RAS wild type nodules maybe is less aggressive lesion compared to the RAS mutational, with the NIFT-P with the RAS mutation. So up to now, we have always heard about spatial proteomics, spatial lipidomics, metabolomics, and glycomics, but maybe we are going into a new direction, which I like to call spatial interactomics, or as in the case of NIFT-P, spatial interrasomics. Let's see where this will bring us. So, which is the future now? So we are in the era of digital pathology, and mass spectrometry imaging could be actually used by the pathologists to integrate the molecular image with the histological one to go back and forward and try to give to the nodule a better diagnosis. This for what regards the cytological samples, but of course, using the tissue samples with mass spectrometry imaging, we can even have more information about the biological context. And we can even identify potential molecular biomarker that can be then translated in immunohistochemistry. So now you have an idea of what mass spectrometry imaging can do in digital pathology and to advance the precision medicine of those patients which are actually indeterminate. With that, I would like to conclude my presentation and to thank the research group led by Professor Magni and, of course, Professor Pagni from the San Gerardo, and all of you for the kind attention.
Grazie per la presentazione. Ci sono delle domande?
Just a curiosity, because you talk about pixel by pixel segmentation, so my question is, which is the actual resolution of the pixel, which is the size of the pixel, yes, and which is the physical limitation why you cannot reduce the resolution?
Yes, so the lateral resolution that we have used in those analyses was 50 micron analysis, but the technique can even reach higher spatial resolution. Now we have instrumentation that we can even go to single cell analysis, so we can analyze up to 10 micron of spatial resolution, but it wasn't the focus of this study, because with 50 micron we could really select the region containing benign or malignant thyrocytes, so we didn't want to go really to one single cell. And even in tissue analysis, we decided to go for 50 micron because we had very big tissues. And with 10 micron of analysis, you would generate a huge, huge data set. And it will become very hard then to do the data elaboration.
So thank you for your talk. So my question is about spatial transcriptomics. You mentioned many omics. Do you see also room for spatial transcriptomics in this project?
So I have never done spatial transcriptomics. I'm a mass spectrometry expert. But yes, why not? I mean, I believe that more layer of information we can integrate, better is the information, the biological information that we can actually get from our samples, of course.
Ci sono altre domande? Allora te ne faccio una io. Questa metodica che hai presentato può essere utilizzata in diagnostica, ma dal punto di vista economico qual è l'impatto che avrebbe?
Allora, la tecnica potenzialmente può essere utilizzata in diagnostica. Io vi ho mostrato ovviamente un workflow ipotetico. Come vi ho fatto vedere, abbiamo sfruttato i primi anni allo sviluppo dell'approccio proprio per ridurre anche i costi. Un tempo avevamo un vetrino con dei costi anche abbastanza elevati per un singolo campione. Con il metodo ottimizzato oggi abbiamo un singolo vetrino e 8 campioni per vetrino, quindi già abbiamo abbattuto tanto i costi della sample preparation. Bisogna anche considerare che all'interno del contesto clinico la tecnica di spettrometria di massa è già arrivata nel momento in cui è presente il MAL di Biotyper, che è una strumentazione adatta per la caratterizzazione dei batteri. Quindi in un futuro non escludo il fatto che si possa anche pensare di sviluppare una tecnologia che consenta di fare quello che vi ho mostrato in condizioni meno costose e utilizzabile da un semplice tecnico.
Se non ci sono altre domande, grazie.
Grazie.
Possiamo quindi dichiarare chiusa questa prima parte, abbiamo un quarto d'ora di pausa e poi passeremo alla parte delle presentazioni relative alla ricerca clinica. Grazie, a dopo.
Buongiorno a tutti, riprendiamo questa seconda sessione del Dipartimento. La sessione sarà dedicata appunto agli studi clinici, presenteranno ancora 3 ricercatori. Apriamo la sessione con Alessio Gerussi, ricercatore in ambito gastroenterologia. Il titolo della sua presentazione sarà Deep Learning can discriminate between autoimmune hepatitis and primary biliary cholangitis directly from digital histology slides. A te la parola.
Okay, good morning everyone. So today I will briefly present some preliminary data about the application of AI to images derived from liver biopsy in autoimmune liver disease. Yeah. Okay, so the 2 conditions that I will describe are autoimmune hepatitis, AIH, and primary biliary cholangitis, PBC. So these 2 conditions affect the liver in a different way. AIH, autoimmune hepatitis, is a chronic liver disease, so it mostly affects the hepatocyte, and there is liver cell inflammation, and is treated with immunosuppression. So immunosuppression means that these are drugs that lowers the function and the activity of the immune system, because these are autoimmune diseases. Primary biliary cholangitis affects the small biliary tract, so the small bile ducts. So there is bile duct inflammation and bile duct loss, but as compared to AIH, it is treated with choleretic drugs, so with drugs like ursodeoxycholic acid that makes the bile less toxic, and so they reduce and dampen the inflammation due to the stasis of the bile. So a problem that you see in clinic is the overlap syndrome. So around 10% of patients, despite these are rare conditions, can have overlapping features. So it means that they can show features and symptoms and clinical variables, same biochemistry, that belongs to both conditions. So for example, there could be an hepatic phenotype together with a biliary phenotype in the same individual. So these patients are particularly difficult to treat, to diagnose, and to manage, and they represent an unmet need in our field. Interface hepatitis is a mainstay diagnostic aspect and feature of autoimmune hepatitis. And basically, here you can see the portal triad, so a region of the liver tissue where you can find a branch of the artery, hepatic artery, of the portal vein and bile duct. And you can see clearly that there is an infiltrate of immune cells, so there is a lot of inflammation. And so we can say that there is portal tract inflammation, portal inflammation. So when portal inflammation goes beyond the portal tract, we can call it periportal inflammation or interface hepatitis, because it involves the interface between the lobule and the portal triad. So this feature is often seen in AIH, in autoimmune hepatitis, and the pathologists look for it. And it grades the severity according to mild, moderate, or severe, so in a semi-qualitative or semi-quantitative fashion. But unfortunately, also PBC can show this feature, and also other conditions like viral hepatitis, but we don't biopsy viral hepatitis anymore. So the problem is that it is difficult to basically manage those patients with PBC that show interface hepatitis, because clinicians can give them immunosuppression even though that's not necessary for the patient. And in this picture, you can clearly see that from data, historical data, patients with AIH mostly have severe interface hepatitis, but some of them have also mild to moderate interface hepatitis, while patients with PBC that are represented by the blue line can have even severe interface hepatitis and often mild to moderate. So the fact is that to just find in a pathological report the presence of interface hepatitis in a patient with PBC doesn't mean automatically that this patient needs immunosuppression. But unfortunately, this is not often the case, and many patients with PBC are treated with immunosuppression in the ward with significant short and long-term side effects. So this is the clinical problem. And so the question is, how can we leverage the power of AI to help the pathologist and the clinician to discriminate between autoimmune hepatitis and primary biliary cholangitis, especially when there is an overlapping feature. And so to start with some definitions, we have AI, machine learning, and deep learning. So artificial intelligence is the field of computer science that aims to build machines that can mimic the intelligence of human beings. Machine learning is a subtype of AI, and it creates algorithms that help computers to learn from data and make predictions, even though they are not explicitly programmed to do so. So just learning from data how to do that. Deep learning is even more sophisticated and a subtype of AI, and it involves these artificial neural networks that are inspired by the functioning of human brain. So let's talk more about deep learning. So in deep learning, there are these neurons that are basically interconnected nodes, and they are organized into layers. The most important layer is the input layers that receives the initial data. So you can see these nodes, these are the input layer, and they are connected with other nodes downstream. So the information flows forward, and as the information flows, the complexity of information becomes more abstract and higher. So there are several hidden units and the connection between the units is assessed by weights. So these weights are initially set at random, and as you feed the model with training data, they are adjusted to better adapt the output, so the prediction. So the final layer is the output layer. So basically, if you ask to a neural network to classify something, whether a benign lesion versus a neoplastic lesion, for example, the output is this classification, and that is based on the input that you provided. The more data you give, the more training the deep learning has, the more sophisticated is the prediction based on the adjustment of weights. So an application can be the use of images, so to feed this neural network with images. So you can give images with annotation, so the pathologist has to actively annotate the image and say this is a portal trial, this is a lobule, this is a centrilobular vein, or you can give the image as it is. In any case, what is the goal is to transform this pixel, the information that is embedded inside this image, into a vector of features to predict and to classify some output. And this is now performed a lot in oncology, so there are several papers that show the potential of this approach in classifying lesions from pathological tissues, from surgical tissues, but also retinal images and so forth. So basically what we decided to do was to try to, let me just say, to try this approach in autoimmune liver disease. But first, I want to show you, this is a funny image. And so neural network basically, if you provide images, has to define and classify whether the image that you provide is a chihuahua or a muffin. That's the idea. So, and the image has its own architecture, and based on that and based on training, the neural network will do that in a very excellent way. So the aim of the study, as a general goal, is to study the power of a convolutional neural network, which is a particular type of neural network that is typically used to analyze images, to differentiate between autoimmune hepatitis and PBC based on images derived from liver biopsy, but without annotation, so without giving the information, the pathological information. And so this is the workflow. So in collaboration with the Department of Pathology, so Professor Pagni and team, we had the opportunity to start digitalizing the whole liver biopsy set from our unit. And then we started a collaboration with other centers within the PBC and the IH registry in Italy and also involved another center in Germany, in Hanover. So now we have 6 centers involved and more than 400 patients with AIH, more than 250 patients with PBC. These patients are treatment naive because we didn't want to change the biology so we didn't want to change the biology with medications. So these biopsies have been taken at diagnosis. And the deep learning analysis are performed in the Center of Clinical Artificial Intelligence Lab in Dresden, directed by Professor Kater. Professor Kater is working actively on this topic, but mostly on the gastrointestinal oncology side. So this is the first time that even their lab applies their model to inflammatory fibrotic diseases like autoimmune liver disease. So after taking the liver biopsy, we use this Aperio image scan. There are also other softwares to digitally scan this biopsy. And then these images are shared with the Kater's lab, and they are tested in several tiles, so many tiles that feed the neural network. So basically, the input layer in this study is constituted by these thousands of tiles. And then the neural network has the output, the classification between one disease versus the other. And so we can evaluate the quality, so the accuracy of this classification, and then we can create heat map to further understand what happened and what are the areas that the deep learning, so the model, has used to make this distinction. So the first results, this is the second round of analysis, show that the deep learning machine is particularly accurate in discriminating with very few errors. This is confirmed and consistent when there is a cross-validation, so internal validation, and when we use external controls. But then the question is, okay, but what's happening here? Because this is a black box model, and we don't like black box model, especially in the clinic. We want to move forward toward explainable AI process. And from a pathological point of view, we want to help the pathologist to understand what are the significant areas that have been used by the machine, so by the model, and to guide also the non-expert pathologist to the areas that where he has or she has to focus the attention. And so we can use heat maps. So this is a paper from Nature Medicine last year on rejection in heart transplant. And so also in this paper, they use the deep learning model to differentiate different types of rejection. And then to further understand what the neural networks have performed, they use this attention map, these heat maps. And so the more red, the more important that area for classification. And the more blue, the less important. So the heat maps are here to help the visualization and also to interpret the model predictions. So this is the original slide. This is just an example for you of a PBC sample, so a patient with primary biliary cholangitis. This is a portal triad. There is a lot of inflammation, bile duct loss, and the heat map is basically overlapped. And you can clearly see that if there is that area, so the portal area, is more red, and the lobule is more bluish. So that means that we need to focus our attention in the next steps on that area, and that probably the neural networks have used mostly that area to classify and differentiate between one disease versus the other, so between AIH and PBC, rather than the lobule. So the first conclusions, the preliminary data are the convolutional neural networks are able to differentiate between AIH and PBC by reading liver slides, and the important aspect is that we didn't annotate these slides. So it was a sort of semi-supervised, unsupervised approach. And then that heat maps show that regions with high score correspond to diagnostically relevant morphology in AIH and PBC, and this is not trivial because, of course, there could be biases, so there could be tricks that the model used. So this is not the case because it used something that is well grounded on the biology and the morphology that we typically see in these patients. And some next steps, so the next steps are to test the algorithm now with overlap cases, because this is the center of our study. So we want to feed now the model with these cases and see, having a quantitative score, what is the output. So if it is still accurate when you provide these cases. Then compare the performance of the machine, of the model, with that of the pathologist and see if it is equally accurate, better, worse. And this is important for the clinical application at the pathological level. Then, since these are not annotated slides, we need to know these features that have been derived by the neural network, what is their biological meaning, so how to correlate them with clinical data and find what are these AI-driven biomarkers. And finally, potentially integrate in the clinical diagnostic workflow also the quantitative information derived from the pathological slide. So I really want to acknowledge all the group of the Center of Autoimmune Liver Disease here, the collaborators, and you for your attention.
Grazie mille per questa presentazione che riprende anche alcuni aspetti dell'ultima presentazione che abbiamo visto nella prima sessione. Apriamo le domande dal pubblico.
A very nice presentation, very nice data. One curiosity. We have seen in an earlier presentation the power of mass spectrometry in order to classify different kind of samples. Do you think that this kind of technology will overcome the mass spectrometry approach in future? And based on its applicability, we knew that mass spectrometry needs some years in order to become routine, but what about your technology?
So I don't think it will overcome mass spectrometry because, to be fair, we are collaborating with the group of Professor Magni to further understand what is the biology behind this automatic process. So I think these techniques provide complementary information that we can put together. I asked to the previous talk whether spatial transcriptomics can be used. So the idea is to move forward toward a multimodal data integration, right, from different techniques. And AI can be the tool that put together these different layers of data. This is not easy because there are computer scientists spending their life in finding the best way to do so, and also avoiding biases, because of course there is the so-called batch effect when you put together data from different techniques, different centers, different protocols. Yeah.
Thanks, Alessio, for a wonderful presentation. I just wanted to ask, I imagine the scope also in the future is to apply this algorithm to images generated from multiple different centers. Do you think the machine learning algorithm will need to be modified to account for differences in the images obtained from different scanners, so therefore have different contrasts, or is applicable as is?
So thank you. That's a very important question. So what we did here was already in that direction, was moving already in that direction, because we have taken biopsy from different centers, different scanners also, because I mentioned our scanner, but the other centers, Hanover had another scanner. So we are already trying to stress the system in that direction. Yeah.
I would like to thank you and to thank Dr. Piga to show us the different possibility to apply different digital pathology tools in our routine. And this is the main aim of many of our projects as the Department of Excellence of UNIMIB, and a great opportunity to upgrade our departments, not only pathology department, but also clinical department. You showed that omics, transcriptomics or proteomics may be part of the diagnostic workflow, of the routine diagnostic workflow in the next future. And the other message for all of us, in my opinion, is to upgrade dramatically the trackability of the routine workflow in our department. It's a great issue. We are in many areas in the analogic area. We should move to the digital one, and this is our mission for the next 4 years of our project. So thank you, Alessio, for this great opportunity, and we have a hard job to do.
Yeah, I can't agree more than, yeah, of course. Yeah, thanks for the comment.
Ok, ti faccio un'ultima domanda io. Appunto, tornando indietro al ruolo del patologo, il gold standard qui è stata la diagnosi del patologo contro cui avete confrontato, diciamo, i campioni?
No, abbiamo usato una diagnosi che doveva essere sia confermata a livello patologico ma anche clinico, perché comunque la diagnosi non è mai solo patologica, proprio perché gli spettri fenotipici a livello patologico possono overlappare, quindi per esempio l'epatite interfaccia può esserci in tutte e due. Quindi è proprio questo l'elemento che vogliamo sottolineare, il fatto che il patologo a volte è un po' in difficoltà in questi quadri un po' sfumati, e quindi in realtà la diagnosi doveva essere confermata anche dal clinico. Quindi lo studio ha un duplice effetto, potrebbe essere applicato dal patologo, soprattutto il patologo non esperto che si trova a affrontare malattie rare e quindi gli può dare un aiuto, quindi è un supporto quello che fornirebbe le AI. Al clinico invece eventualmente avere uno score più quantitativo rispetto a qualcosa che è molto diciamo divergente, eterogeneo da patologo a patologo, perché al momento viene fatto uno score che è o qualitativo o tipo moderata severa. Avere una quantitizzazione e metterlo in un modello clinico potrebbe migliorare molto la nostra diagnosi.
Però è corretto, dal punto di vista dell'algoritmo attualmente è solo in grado di, chiamiamolo, individuare aree ad alta cellularità rispetto ad aree risparmiate da malattia, di fatto, giusto? Cioè quelle mappe di colore che tu ci hai mostrato.
Sì, allora diciamo che quello è uno dei primi modi con cui abbiamo iniziato ad affrontare il problema di capire che cosa sta facendo la macchina, proprio perché non hai annotato, perché annotare significa che un patologo deve annotare centinaia, quindi il campo generalmente si sta muovendo verso algoritmi che magari lo fanno per te, quindi semi-supervisionati, tu glielo insegni magari in 30-40 slide. Chiaramente per studi più raffinati, in cui tu vuoi studiare bene la biologia, è fondamentale l'annotation, però magari lo fai per una serie di slide e poi magari, che ne so, ci fai la proteomica, ci fai la spatial transcriptomics.
Se non ci sono altre domande, ringraziamo il dottor Giarussi e chiamiamo la dottoressa... La dottoressa Elisabetta Colciago, assenista di ricerca in ginecologia e ostetricia, che ci presenta Mode of Birth in Women with Low-Lyme Placenta, the Model Placenta Study.
So, thank you, and good morning, everybody. Today I will show you how we Today I will show you why we need to offer a vaginal birth to women that has during pregnancy a placenta located in an abnormal place in the uterus. And where did we start? In 2012, the British Medical Journal came up with a general statement saying that doing too much screening, doing too much interventions that are not required, we are harming people. So probably we are harming especially healthy people, because we are expanding the definition of disease. And this statement was referred to all clinical fields and was also for maternity. And the same concept was taken from the Lancet Maternity series in 2018, and this series highlighted that on the continuum of maternity pathway, there are two extreme situations. One is called too little, too late, and describes a situation where we have an unsafe maternity care, a substandard maternity care, which is often unavailable, so leading to high maternal mortality and morbidity. But on the contrary, we have another situation situation where called too much too soon, which describes a situation where there is a routine medicalization of pregnancy and childbirth, and so we have a maternity care that is often based on non-evidence-based intervention, and also this type of care can be harmful, can be disrespectful, and also causing a large waste of money for our healthcare system. So this second phenomenon is typical of the high-income countries where we can see the tip of an iceberg. We can see that often we do too much cesarean section that are without an indication, without a clinical indication, are unnecessary and inappropriate. But underneath, there is this situation that we called too much too soon. So too much interventions that are often non-evidence-based and leading to unnecessary cesarean section. That is what we see. Since 2015, the World Health Organization recommended that we must achieve a rate of cesarean section between 10 and 15, because studies demonstrate that a higher percentage failed to give better outcomes for mothers and for babies. So in Italy, we have still a long way to go, but now we have a 32% of cesarean section, and we are getting better, because a few years ago we had a 37% of cesarean section, and we had also the black flag in Europe with Cyprus for the highest rate of cesarean section. And why is it important to avoid any unnecessary cesarean section? Because the cesarean sections are, of course, a major surgical procedure, which is life-saving sometimes, so might be necessary, but most of the times, unfortunately, in our country and in other high-income countries, is inappropriate. So the cesarean section gives lots of complications, which are early, medium, and also in the long term. And with our project, we want to focus especially on preventing the complication for future pregnancies, because we know that the cesarean section is a very important risk factor for complication in subsequent pregnancies. So why we want to prevent this? Because we know that a previous cesarean section is a very high risk to develop an abnormal placentation. As you see here, we've got a normal placenta. A normal placenta is very far from the cervix, so is normally in the fundus of the uterus, or can be in a lateral position. And sometimes, especially when we have a previous cesarean section, we have a low-lying placenta. A low-lying placenta is a placenta very close to the cervix, and we name the low-lying placenta when the placenta is between 1 and 20 millimeters from the cervix. We can have also a placenta previa, which is even worse, because the placenta covers completely the cervix, or is over, it reaches the cervix. What can happen is also that during pregnancy, the uterus, of course, grows, and the placenta, which is at the beginning of the pregnancy, low-lying or previa, might move up, and so might become a normal placenta. And this can happen in nearly 90% of cases of those type of placentas. So the recommendations are that when we have a placenta previa, the most appropriate mode of birth is a cesarean section. Why? Because these women during pregnancy have a higher risk of bleeding, have a higher risk of bleeding during childbirth, and of course, as you see, the baby has not enough room to go through the birth canal and be delivered vaginally. But evidence, there is no consensus about the most appropriate mode of delivery in this case, where the placenta doesn't reach, doesn't cover the cervix. We don't know yet how the women should deliver to be in the safe side. So we know from evidence and recommendation around this topic are very different. For example, we have the American English College of Obstetricians and Gynecologists that says that women must have an individualized care when they have a low-lying placenta. However, they basically suggest to offer a cesarean section. On the contrary, we have the more recent guideline from Canada who recommend a vaginal birth for the women who has a distance between the cervix and the placental edge of 11 to 20 millimeters. And they remain open for women who has a placenta which is even closer to the cervix, so between 1 and 20 millimeters. What do we do in Italy? Unfortunately, normally these women receive a cesarean section. But in Monza, we have a very great experience on women with a placenta that is between 11 and 20 millimeters. So we offer to all these women since 2009 the opportunity to give birth vaginally. So with our study, we want to do even better. We would like to evaluate the rate of vaginal birth and the rate of cesarean section due to bleeding in these women, and in particular in women who has a placenta with a distance between the cervix and the placental edge between 6 and 20 millimeters. So we are running this study in 9 maternity units around the Lombardy region. And our study is a case control study. It means that for each case, we are taking 3 controls. So one case is matched with the 3 controls, and the controls are women with a normal placenta throughout the pregnancy. Cases are women with a placenta previa, women with a low-lying placenta that I showed you before, and those women with a placenta that became normal during pregnancy. Why we included this placenta that we call the placenta resolved in the cases group? Because also these women, from emerging evidence, we know that they might have a higher risk of bleeding at birth. So the risk of bleeding in case of placenta previa is too high, so the baby can be delivered vaginally, but we need to understand what is the risk in this case and what is the risk in the case of a resolved placenta. And the diagnosis of the location of the placenta is made through a transvaginal scanning. For our project, we should make a diagnosis between 19 and 23 weeks plus 6 days of pregnancy. These women are looked after in a dedicated clinic with a dedicated team. So they will have a follow-up between 28 and 32 weeks. If those women will have a normal placenta, so a resolved placenta at these weeks of pregnancy, they will follow the normal pathway during pregnancy. Otherwise, they will continue to be looked after in this dedicated clinic, and the follow-up will continue until birth. So I will show you some data, which are very preliminary data. We collected 173 cases, dividing among placenta previa and low-lying placenta at 20 weeks of pregnancy. And we collected 303 controls. We know that from women that have a placenta previa at 20 weeks are more likely to have a posterior placenta. It means a placenta located on the posterior wall of the uterus, so it means behind the baby. Why is important this information? Because from emerging evidence, we know that probably these type of placenta, which are on the posterior wall instead of being in the anterior wall, I have a less frequently move up, so are less likely to become resolved. These women have most of the time achieved this pregnancy through an assisted reproductive technology. Also, this is an important information because we know from the evidence that this is true. I mean, people that develop this kind of placenta go through an assisted reproductive pathway and doesn't have a spontaneous pregnancy. Both of the placenta, so placenta previa and the low-lying placenta, are more likely to be admitted during pregnancy due to bleeding, unfortunately. And of course, women that have 20 weeks of pregnancy, a placenta previa, are more likely to have a premature birth with a baby which is lethal. The low-lying placenta are women also that have in their previous history a uterine cavity revision. So why is important? Because we want to understand the rate of vaginal birth. We have the birth of 155 cases because we are waiting that the other maternity units report their data. At term, 32 women remain with a placenta previa. 105 women had a resolved placenta. It means that we have a resolution rate of 60%. This is much lower than the one that we can find in the literature, which is nearly 90%. So probably this is because we need to collect more data. And the vaginal birth rate in these women is for now 85%, 86%. We had 18 women with a low-lying placenta, a persistent low-lying placenta at term. These women delivered vaginally in 45% of cases, and this rate is much lower than the one that we had during previous studies in Monza, because in our cases we have a rate of 77% of vaginal birth. So probably we need to understand better what is not maybe working in other maternity units. And of course the controls, so women that had a normal placenta since the beginning had a very high rate of vaginal birth. We compared the vaginal birth between resolved placenta, low-lying placenta, and control. So what we saw, we found that the women with a persistent low-lying placenta need more medication to contract the uterus after birth, and they have a higher risk of higher blood after the birth. So we can even see that also these women carries risks after birth. For the women with a persistent low-lying placenta, we found that they need more often a manual removal of the placenta, the revision of the uterine cavity, and a balloon to be inserted in the uterus to maintain the uterus contract. But what happened when we focused only to compare resolved placenta versus controls? We found that this type of placenta still are more likely to need interventions to contract the uterus, so probably to stop the bleeding, and also they have higher bleeding after birth. So looking at this data, we asked ourselves why there is this big deal about low-lying placenta, why we used to offer a vaginal birth without any doubts, without any problem to all women who has a resolved placenta, and not to the women with a persistent placenta low-lying at birth. So we need more data. we need to focus and reflect about evidence-based medicine. We need to collect more information because, of course, we need more information to give more knowledge to clinicians, but first of all, we need more knowledge to offer an evidence-based care to women, an evidence-based and an appropriate counseling to these women, and with our project we hope to improve our national surgical birth practice on this field. And because this will be the larger and prospective study on this topic, we hope we can make the difference and inform future international guidelines about the most appropriate mode of birth for these women with a low-lying placenta, persistent low-lying placenta at term of pregnancy. I want to thank you, my team. This is the team working in Monza for this project. We are all women, and of course there are also all the other clinicians around the Lombardy regions that are working hard to collect data. And thank you to everybody here.
Grazie, dottoressa Colciago. Anche in questa presentazione abbiamo visto che ci sono degli elementi che riprendono le presentazioni della prima sessione, la questione del harming the healthy o tutta la questione dell'overtreating e quindi delle spese aumentate non necessarie. Apriamo le domande, se qualcuno dal pubblico.
Spiazzati dalla placenta.
Grazie. Ok, si è ripreso, si è ripreso. Ok, grazie, ovviamente non sono dell'ambito, posso fare una domanda assurda, quindi sei autorizzata a mandarmi a quel paese. No, mi chiedevo, molto interessante questo aspetto, un altro aspetto che non so se possa essere correlato o meno, appunto alla morfologia della placenta, anche il trattamento con epidurale, che è un'altra cosa che mi sembra vada molto di moda, al quale io personalmente mi sono opposta in modo fervido dicendo, beh, la natura vuole altro, no? Però mi chiedevo se ci fosse non so, o se sono cose che assolutamente non hanno alcuna relazione tra di loro, anche eventualmente su maternità multiple, no? Quindi magari possano essere correlate come fattore di rischio. L'epidurale mi riferisco ovviamente a alterazione della placenta, assolutamente no.
Ok. Allora, una precedente epidurale o fare un'epidurale non ha nulla a che vedere con la formazione della placenta nelle gravidanze successive. Il discorso dell'epidurale si collega un po' a questo discorso sulla medicalizzazione del parto, e certamente l'epidurale è un grandissimo aiuto che alcune donne assolutamente necessitano e hanno il diritto di richiedere. Come tutte le cose dovrebbero avere un'indicazione medica, perché non hanno niente a che fare con la placenta, hanno solamente a che fare con un processo di travaglio e parto che ovviamente non è più fisiologico, ma l'epidurale può comportare delle piccole deviazioni dalla normalità. Ecco.
Una curiosità, si può quantificare il rischio, cioè, di possibili complicanze dopo un primo taglio cesareo? E un'altra domanda era, è possibile invece, qual è la possibilità di avere un parto naturale dopo un primo taglio cesareo?
Ok, allora sì, è possibile quantificare, non tutti i rischi, è possibile quantificare. Ad esempio noi abbiamo uno studio sulla mortalità materna in Italia, e noi sappiamo che la mortalità con taglio cesareo è 4 volte superiore rispetto a un parto che avviene vaginalmente. Abbiamo ovviamente un alto tasso di infezioni, di emorragia postpartum, e infatti anche con una placentazione anomala noi abbiamo un rischio di emorragia postpartum che è maggiore nelle donne che hanno un taglio cesareo nei casi di placenta low lying rispetto alle donne che invece partoriscono vaginalmente, quindi anche questo, e ovviamente i rischi maggiori sono per le gravidanze future, prima di tutto perché si è visto che donne purtroppo che hanno un taglio cesareo hanno un'esperienza di travaglio e parto che è meno soddisfacente delle donne che hanno un parto vaginale, e questo dipende da noi. Quindi noi dobbiamo anche modificare e migliorare la care che diamo alle donne che devono fare un taglio cesareo, e inoltre il fatto appunto di avere una minor soddisfazione può portare le donne a scegliere di non avere più figli. Quindi anche questo è un grandissimo evento avverso, un rischio che non sappiamo quantificare in questo momento, ma sappiamo che esiste. Per quanto riguarda la seconda domanda, in letteratura anni fa, quindi a partire dal 1970-1980, quando è iniziato questa grande medicalizzazione del parto e della gravidanza nel mondo occidentale, si diceva che un taglio cesareo porta sempre altri tagli cesarei. Invece la letteratura assolutamente non conferma questo, anzi tutte le linee guida raccomandano di offrire un parto vaginale alle donne con un precedente parto cesareo alle spalle, e ci sono degli studi che arrivano ad una percentuale di successo di parto vaginale che si aggira intorno all'85%. Noi a Monza, ad esempio, abbiamo una storia comunque di protezione della fisiologia che ha la gravidanza e il travaglio, perché sono fenomeni che avvengono quotidianamente nella vita della donna, anche se non siamo più abituati magari come una volta a percepirli come quotidiani, ma il nostro tasso si aggira intorno al 70-75%, che è uno dei più alti in Italia purtroppo, perché negli altri ospedali si tende a offrire un taglio cesareo dopo il primo taglio cesareo.
Grazie per la presentazione. La mia è una domanda veramente di una persona che poco, diciamo, però mi incuriosisce molto. La posizione della placenta normale, placenta più bassa, placenta previa, ma è legata a una predisposizione della donna? Ci sono alcuni fattori che determinano questo? Se una donna, per esempio, ha avuto una gravidanza con la placenta previa, la successiva per forza deve essere con la previa? Cioè, vorrei avere un attimo di informazioni, così, che per voi è di base, ma per avere un quadro più chiaro. Grazie.
Allora, grazie per la domanda. In realtà non è affatto chiaro, neanche per noi, perché noi tuttora, fortunatamente l'ostetricia è la branca della medicina con meno sicurezze in assoluto, fortunatamente per certi versi. Noi non sappiamo ancora l'esatto motivo per cui una placenta diventa previa o low lying. Noi sappiamo, come abbiamo visto nel nostro studio, che ci sono probabilmente dei fattori di rischio. Ad esempio nel nostro studio il maggior fattore di rischio, che è il taglio cesareo pregresso, non è ancora uscito, quindi noi probabilmente abbiamo bisogno di più dati. Sappiamo che un taglio cesareo pregresso o ad esempio una revisione della cavità uterina avvenuta in precedenti gravidanze formano un tessuto cicatriziale all'interno dell'utero, quindi questo potrebbe causare una formazione della placenta anomala all'interno degli strati dell'organo utero. Un altro fattore di rischio che è già evidente all'interno del nostro studio sono le donne che hanno raggiunto la gravidanza con la procreazione medicalmente assistita. Quindi anche in questo caso i rischi in generale aumentano e purtroppo aumenta anche questo. Altri fattori di rischio che non sono per la formazione, ma appunto il nostro studio, anche quello precedente, e una revisione sistematica e meta-analisi del 2019 ci mostra che appunto una placenta sulla parete posteriore dell'utero porta a queste placente che sono già non fisiologiche a muoversi ancora di meno. Quindi ci sono dei fattori di rischio che noi dobbiamo studiare, ma non sono ancora chiari nemmeno in letteratura. Comunque il più grosso sembra essere il fattore di rischio precedente taglio cesareo, e più precedenti tagli cesarei alla donna, più grande sarà il rischio. Il rischio maggiore poi è anche quello che è chiamato spettro dell'accretismo placentare, quindi quando la placenta non si instaura solamente nel primo piano del miometrio, okay, che è il tessuto interno dell'utero, ma va oltre. In questo caso purtroppo il rischio è anche di avere molto spesso un'isterectomia. Quindi il taglio cesareo è sempre meglio evitarlo, soprattutto il primo. Quindi noi dobbiamo lavorare sull'evitare il primo taglio cesareo nella vita di una donna.
Ho una domanda io.
Sì.
Anestesista, è bene fare questa precisazione. Quel 44% di successi, quindi parti vaginali, corrisponde chiaramente a un equivalente, insomma quello che manca, 56% di poi tagli cesari. Sono tagli cesari, immagino che sono state riconversioni di fatto, perché avendo offerto tutto il parto vaginale siete partiti per quella via e dopodiché avete modificato il percorso in corsa. Quali sono stati i criteri oggettivi, o avete stabilito dei criteri oggettivi attraverso i quali dite ok, abbiamo dato la possibilità ma non è più ragionevole proseguire, e se questo approccio ha provocato magari appunto riconversioni rispetto a parti vaginali, anche modifiche nei parametri del feto, quindi Apgar 5 minuti, avete guardato segni di sofferenza fetale nel caso di ritardo alla conversione sul cesareo, perché magari avete preferito proseguire verso
Sì.
C-section.
No, grazie per la domanda, perché è una cosa che poi nella presentazione non ho detto, ma questo basso tasso di parti vaginali che noi ci aspettiamo e speriamo aumenti è dovuto principalmente a fattori come la malpresentazione fetale o una malposizione. Vuol dire che spesso purtroppo la placenta, essendo in una posizione molto vicina alla cervice, all'orificio uterino interno, dove è presente la parte presentata fetale, quindi la testa, spesso impedisce alla testa di posizionarsi nel modo migliore per il parto. Quindi il parto purtroppo non avviene anche dopo tentativi, e quindi si deve fare un taglio cesareo. Quello che interessava a noi era vedere quante donne in realtà poi fanno un taglio cesareo perché hanno delle perdite ematiche dovute principalmente, pensiamo, alla placenta. In questo caso su 18 donne 4 hanno avuto perdite ematiche in travaglio che hanno richiesto un taglio cesareo urgente, erano donne all'interno del gruppo con una distanza tra 11 e 20. Noi sappiamo in letteratura, da questa grande meta-analisi uscita nel 2019, che tra l'altro suggerisce di offrire un parto vaginale a tutte le donne che hanno una distanza tra 1 e 20 mm, che il tasso di taglio cesareo è il 14% per perdite ematiche nelle donne che hanno una distanza tra 11 e 20 e del 45% nelle donne che hanno una distanza tra 1 e 10. Tuttavia, non essendosi dimostrati dei rischi elevati né per la madre né per il bambino, anche nel nostro studio, anche gli autori di quella meta-analisi suggeriscono assolutamente che vale la pena offrire un parto vaginale alle donne. Per quanto riguarda nello specifico i nostri dati, a parte ovviamente i bambini che nelle donne che hanno una placenta previa a termine nascono prima, perché il taglio cesareo è raccomandato tra la 36esima e la 37esima settimana, proprio per evitare le copiose perdite ematiche che in quel caso sono abbastanza frequenti. Quindi il parto prematuro e il basso peso alla nascita. Per il resto non abbiamo avuti più ricoveri in teen o più ricoveri anche delle mamme in terapia intensiva o con dei problemi gravi dopo il parto.
Ultima domanda, appunto questo. Voi avete detto che voi siete chiaramente un centro terziario abituato a fare parti vaginali. Qual è secondo te l'applicabilità in centri che non hanno la TIN, per esempio, o un'emoteca disponibile o via dicendo? Cioè, perché poi ci si scontra con la realtà di ospedali magari periferici che devono prendere un'ambulanza se qualcosa va male e trasferire mamma e bambino.
Certo. Allora, infatti, in questo assolutamente una placenta previa dovrebbe essere presa in carico in un centro di secondo livello, come Monza. Noi nelle 9 maternità che abbiamo incluso ci sono anche ospedali di primo livello che comunque sono abituati a offrire parti vaginali, ma assolutamente donne con questi fattori di rischio importanti devono essere trasferite in questi centri in cui ci sono tutti i servizi per fronteggiare un rischio elevato di perdita.
Va bene.
Va bene.
Proseguiamo, grazie.
Grazie mille.
Allora, lasciamo la parola al prossimo speaker, dottoressa Martinelli, Marianna, ricercatrice in ambito di microbiologia e microbiologia clinica. La sua presentazione ha il titolo Human Papilloma Virus Infection and Cervical Cancer, New Prevention Strategies. Ok.
Thank you very much for the presentation. And thank you for the opportunity to present the results obtained from this project from our group. Cervical cancer is one of the most common cancer among women population, and as you can see in the maps, the majority of these cases are concentrated in the low-income countries, and unfortunately this type of cancer is responsible for 1,000 deaths, and it is estimated that in 2020 this cancer have caused 342,000 deaths, especially in low-income countries. Fortunately, this type of cancer is preventable, and we have already different preventive strategies to stop and to block this very big problem. Especially, some preventive strategies are available, some primary strategy such as vaccination, and a secondary strategy such as screening programs. To stop this very huge public health problem, the WHO in 2020 has developed the global strategy for cervical cancer elimination, in which suggests to all countries to reach the 90-70-90 targets, that this number refers to some specific goals that each country has to reach by 2030. And is in particular, the 90 refers to the percentage of 90% that each country has to reach of girls fully vaccinated with the HPV vaccine by the age of 15. The number of 70 refers to the 70% of women screened using high-perform tests by the age of 35 and again by the age of 45. And the last 90 refers to the percentage of women with precancer and cancer that has to be managed and treated. It is well known that this kind of cancer is associated with human papillomavirus infection, and there are more than 200 types of this kind of virus known, but luckily not all these kind of viruses are associated with the cancer development. But just few of these genotypes are associated with precancer lesion and cancer development. This type of genotypes are called high-risk HPV genotypes, and I show you later which genotypes are the main involved in this problem. This kind of infection is very common among women population. It is the most common sexually transmitted infection worldwide, and it is also estimated that almost 80% of women acquire this genital infection during their lifetime. Regarding the prevalence, it is variable depending on the country taken into account, and it ranges between 6.5 to 17%. Luckily, this kind of infection, the most of these infections are transient, and just a very few infections tend to persist. More or less 10% of the infection tend to persist and to cause pre-cancer lesion and also cancer lesion. And so why some of these infections tend to persist and some are transient? That's probably because, yes, the HPV is the main cause, but probably there are other addiction risk factors that are associated to the persistence of this infection and also to the progression of some kind of precursor lesions. Regarding this risk factor, some of these factors are related to the humans, so probably to the immune status of the person that acquired this infection. And other factors are related to the viral itself, so it's related to the infection itself. One of the main risk factors related to the virus is the specific genotype. As I told you before, there are more than 200 human papillomaviruses known, but just 12 are recognized to be cancerogenic by the International Agency for Research of Cancer, and other are known as probable and possible carcinogenic for humans, but we have to focus our attention on these high-risk HPV genotypes. In particular, HPV-16 and HPV-18 are responsible together of almost 71% of all cervical cancer. The other most common genotypes that we found in cervical cancer are the genotypes HPV 58, 33, 44, and 31. Another important prevention strategy, another important tool that we have that is available is the screening, the program screening. And recently, some changes has been made also in the screening for cervical cancer, because in the past, the pap test was considered the gold standard and the main test to use for cervical cancer screening. However, recently, a new test was introduced in the screening, and this is the HPV test. And HPV test consists to search the presence of the virus, of the DNA virus, and this test is most sensitive, so we can find more women that are at risk for develop cervical cancer. In particular, European guidelines suggest to continue to perform pap tests in younger women, women aged from 25 to 21 or 33, depending on the country, because in this group of women, HPV infection is very frequent. So if we have to perform HPV tests among this group of women, we could find a lot of false positive. So in this case, it's better to perform a cytological test and go inside and see effectively which is the lesion, the real lesion, and not just the presence of the virus. For older women, for women age from 30 to 64 years, it's suggested to perform the HPV test, and in this case, the sample collected is the same. The sample analysis is a cervical sample, but in this case, we used some molecular methods for the detection of HPV DNA. In case of we found a positivity of HPV DNA, some other triage test has to be done. In this case, HPV positive women perform also a pap test to confirm the presence of possible lesion at the cervix level. In the last years, our groups focused its attention to improve cervical cancer screening in two ways. The first objective was to increase participation to cervical cancer screening. Why? Because even in Italy, there is a great percentage, almost the 12% of women that have never attended to a cervical screening, to cervical cancer screening. And the reason and the question why these women that do not attend to the screening, the response was that they think they don't need it because for laziness and because they had no time to go to the hospital or to the local healthcare centers to collect the cervical sample. And also some of these women respond also that they are afraid or that they are embarrassed from this for this type of collection. To overcome this problem, recently has been suggested to introduce an alternative type of sample to use for the research of HPV DNA. And so the introduction of a new mode for sample collection, that is the self-sampling. The self-sampling that was performed directly by the woman using two different devices or using two different samples. One is the vaginal swab and the other is the urine sample. The use of self-sampling can overcome all this problem about for the participation of cervical cancer screening, because this way of sampling can give the possibility to perform a self-collection at home, and also to overcome any embarrassment, and also the reduction of pain. Another objective that our group is focused on is related also in this case to improve cervical cancer screening, is to find new potential biomarker associated to cervical cancer progression, in particular associated to this infection that tend to persist. Some of these biomarkers that we are studying are the potential of viral load, so the quantity of the virus that infect at the cervical level, the presence of the overexpression of E6 and E7 oncogenic transcript, the presence of specific HPV variants, and also the circulating HPV DNA in blood in women with precancer lesions. So here I show the workflow of the protocol that we are following. And in particular, for the validation of self-sampling, we are following the Valudas protocol, that is an international protocol for the validation of human papillomavirus assay and device collection. And so this protocol focused as the population that we are studying is the women that has a recent cervical dysplasia, and they were referred for a colposcopy for a more induction in depth. And we are collecting samples for these women, and also we are following at different time points these women, depending on their clinical outcome, to evaluate the different biomarkers that I showed you before. All the women that accept to participate to our project, we ask to collect different sample types. In particular, one cervical sample type that is collected from the physician, and before the colposcopy visit, we ask the woman to collect one vaginal self-sample using the flock swab and a urine sample using this specific device that is able to collect the first void urine, that is the part of urine more rich in cells. All these samples will subsequently are subsequently analyzed using molecular methods for the research of HPV DNA, mRNA, and for the sequencing. This graph represents the preliminary result that we have obtained up to now, and we have analyzed up to now 277 samples. And using an HPV test that it is able to detect 28 different HPV types, 14 classified as high risk or probable high risk types, and 14 that are classified as low-risk types. And as you can see in the graph, we observe a very high positivity for the HPV present, but the result is confirmed the fact that these are women referred for colposcopy and women with progression lesions, so the presence of HPV DNA is something expectable. Regarding the going in depth analyzing the HPV types present in this sample, we have observed that HPV 16 and HPV 31 represented the two most common HPV types detected among these women in all three types of sample. And regarding the low-risk HPV types, we observe a very high positivity for HPV 53 and for HPV 42. Making a correlation between the result obtained from cervical sample and to vaginal, compared to vaginal self-sample and urine sample, we have observed a very high concordance with a percentage ranged between 91% urine and 96% in vaginal self-sample. And these results were also confirmed by the kappa value. We also started to study the possible role of viral load, the quantification of viral load in women with cervical dysplasia. And in this very recent publication that we made, and the study that we made, we have seen that we found that a higher viral load among women with SIN2+, so a high-grade lesion, compared to women that has a low-grade lesion, a SIN2- lesion. We also started to analyze the genome obtained from women we have enrolled, and especially we started with 4 different HPV types for the analysis of different viral variants present that infect these women that are accepted to be enrolled in this study. Regarding HPV 16, we found a very high prevalence of lineage A, that is also called the European one. So this is kind of lineage is very common in our country, in our region. Regarding the lineage A was also the prevalent for HPV 18 and also HPV 52. Regarding HPV 31, we found a very high percentage of the lineage C that that infected the women enrolled in this study. So, in conclusion, we can see that the HPV test carried out on self-collected sample demonstrate a very good agreement with respect to cervical sample. So it is important, this evaluation is very important because we can implement some screening program based on HPV, on self-sampling. Regarding the genotype identification, HPV 16, as expected, resulted the most common genotype involved in the high-grade lesions. And regarding the other two possible biomarker, the viral load and the viral variants, we have just obtained the preliminary results, so further analysis are necessary to better understand the use as a potential biomarker. So, in the end, we can say that the introduction of HPV testing on self-sample may be important to improve women's participation for the screening and to achieve the goal established by the WHO. Moreover, the study of the new potential biomarker could refine HPV screening, permitting the distinguished transit for persisting infection responsible for cervical cancer progression. I want to thank all my colleagues and also the people that work at the Gynecology Outpatient Clinic of San Gerardo Hospital, and also people of the Department of Medical Science in Sassari that are collaborating with us. And thank you for your attention. I'm sorry for my voice.
Grazie dottoressa Martinelli per la presentazione. Se la presentazione di prima ci parlava del too much too soon, qui stiamo parlando del too little too late.
Yes.
Forse questo approccio potrebbe, se con costi ovviamente minori, potrebbe andare a migliorare sia le condizioni nei low income countries, come si diceva prima, ma anche mi viene da pensare in alcune popolazioni che ricevono alta stigmatizzazione quando accedono ai servizi sanitari, come ad esempio le persone non binary, gli uomini transgender, che quindi non utilizzano questi servizi di screening, e in generale tutta la popolazione. Prima di aprire il parterre alle domande mi chiedevo, secondo lei quale dei due metodi è migliore, sia in termini di falsi positivi o falsi negativi, ma anche in utilizzabilità delle persone?
Insieme, appunto, quando l'ho riportato, però insieme appunto, quando arruoliamo le donne che partecipano a questo studio, vediamo anche un questionario di gradimento per capire appunto qual è il grado di accettabilità. Entrambi le tipologie di prelievo, sia il tampone vaginale che il campione di urina, sono ben accettati. Diciamo che il campione di urina è sicuramente meno invasivo, però il tampone vaginale è un campione che è più facilmente trasportabile a secco, quindi in questo caso permetterebbe alla donna anche di farlo a casa, nella sua comfort zone, e poi essere spedito appunto anche via posta, perché abbiamo anche dimostrato che questa tipologia di campione rimane stabile, quindi anche la ricerca di HPV rimane stabile nel tempo. Quindi diciamo che magari il campione di urina potrebbe essere utilizzato più da un punto di vista di point of care, quindi anche perché e poi è meno invasivo. Il tampone vaginale potrebbe anche essere utilizzato nel caso in cui debba essere inviato il campione direttamente dalla casa verso il laboratorio, anche via posta.
Grazie. Abbiamo tempo giusto per una o due domande? Professoressa?
HPV infection is also part of the pathogenesis of head and neck cancer.
Yes.
So is this test also useful for diagnosis of the head and neck?
Yes.
And which kind of samples do you use?
Okay. Yes, unfortunately for the HPV-related head and neck cancer, there is no HPV test that can identify the infection at that level, but of course HPV tests can be used, and up to now there are different studies that are evaluating which is the best sample to use. For example, a swab that can be used to collect cells in the mouth, on the oropharynx, and then we can use the same HPV test, maybe related just to the high-risk HPV, for the research of HPV type, and also the saliva can be used.
What about liquid biopsy?
The liquid also there are different studies about liquid biopsy. The majority of them are concentrated on people that has already cancer, so head and neck cancer. In this case, we found a very high percentage of people positive in the blood. So we found HPV DNA in the blood in people with head and neck cancer. So it could be also used as a potential biomarker for recurrence after treatment or also after chemotherapy.
Thank you.
You're welcome.
Grazie mille a tutti gli speaker di stamattina. Ancora un applauso. Chiameremmo sul palco il professor Invernizzi, la professoressa Miloso e il dottor Malacrida per la premiazione del concorso fotografico.
Bene, ha già fatto lei, quindi io non devo stare sul palco, ma venite non solo tu e altri, giusto? Ecco, li chiami tu, lo gestisci, perfetto.
Allora, buongiorno a tutti, adesso chiamo all'appello Alessio Malacrida. Allora, fare andare la presentazione sono negata, quindi aiutatemi. Allora, buongiorno a tutti, finalmente siamo qui con il concorso fotografico. Dite la verità, quanto vi ho stressato, mail su mail, vi incontravo e dicevo mandate foto a più non posso. Beh, finalmente siamo arrivati alla fine. Allora, prima di tutto vi presento il comitato organizzatore
Il comitato organizzatore è costituito in ordine alfabetico dalla dottoressa Michela Luciani, dal dottor Alessio Malacrida, poi dal professor Michele Riva, che è stato chiamato praticamente dalla rettrice proprio in questo momento, ed infine il dottor Francesco Zadek. Io ringrazio veramente tutti quanti loro per la grande collaborazione. Beh, la prima parte sarà cioè già stanno andando in loop tutte le foto. Allora, prima di tutto questo concorso è partito un po' in sordina, diciamo la verità, ma alla fine abbiamo ottenuto veramente un risultato molto ma molto soddisfacente. Allora, io devo fare una serie di ringraziamenti. Prima di tutto ringrazio il direttore del Dipartimento che ci ha supportato in questa iniziativa e ci ha incoraggiato. Poi un ringraziamento va anche a Rossella Guido e all'ufficio legale, perché ragazzi miei, quanta burocrazia c'è dietro questo concorso, voi non la potete neanche immaginare, ve lo assicuro, tantissima burocrazia. Poi ringrazio tutti coloro che hanno partecipato e che si sono messi in gioco, perché bisognava, come dicevo nella scritta, non è necessario essere chissà esperti che cosa, bastava fotografare con il cuore. Quindi io ringrazio veramente tutti i partecipanti e anche coloro che avrebbero voluto partecipare che non hanno partecipato. Mi raccomando per una prossima volta. Ma il principale ringraziamento, diciamo, è al nostro sponsor, al Circolo Imago fotografico di Mugiò, che veramente ci ha supportato in tutto e per tutto con il suo presidente, il signor Nicola Fiore. Allora ci hanno supportato veramente tantissimo, perché i bellissimi premi che daremo ai nostri primi 3 classificati sono donati appunto dal Circolo Imago, un circolo fotografico molto ma molto attivo nell'ambito della fotografia, organizza corsi, un po' di pubblicità anche per loro, perché no, se lo meritano. Sono molto attivi nell'organizzare corsi, nell'organizzare seminari, nell'organizzare anche viaggi fotografici. E quindi un grossissimo ringraziamento al Circolo Imago. Allora, ora vi spiego. Allora, voi state vedendo in loop tutte le foto che sono state presentate. Vi spiego come è avvenuta la votazione, perché è giusto anche che sappiate come è avvenuta. Sono arrivate più di 30 foto e quindi, diciamo, per noi è già un risultato soddisfacente. Io fermavo la gente per strada per dire manda foto, manda foto, manda foto. E il risultato alla fine lo abbiamo avuto. Allora, noi, comitato organizzatore, non c'entriamo assolutamente niente con la scelta delle foto vincitrici, assolutamente niente, perché allora il dottor Malacrida, che ringrazio, permettetemi, in maniera particolare perché mi ha supportato e sopportato soprattutto, allora ha dato a ciascuna foto un numero. Quindi il circolo fotografico Imago si è riunito il 15 giugno e ha visto le foto, ma indicate da un numero. Quindi loro non sapevano assolutamente a chi appartenessero le foto. Le hanno viste più di una volta, con il titolo e senza titolo, in maniera tale da capire anche l'impatto che avevano sulla persona stessa, e poi ciascuno di loro in maniera indipendente ha dato un voto da 1 a 10. Quindi veramente il modo più semplice per poter scegliere delle foto vincitrici. E alla fine hanno vinto le 3 foto che hanno avuto più punti e che adesso appunto vi presento. Allora, la terza classificata è la dottoressa Daunia Laurenti, che non è presente per motivi lavorativi, e ritira il premio alla dottoressa Angelica Squarzoni, ritira la targa. Allora, 2 parole su questa foto. Questa foto si chiama La cura, perché noi ci tenevamo moltissimo anche al titolo della foto. La cura, voi sapete che il concorso era Bicocca per la salute, era veramente un argomento estremamente vario che ognuno poteva interpretare come voleva. La cura in che senso? Non solo la cura come terapia, ma la cura anche come prevenzione, come interesse al paziente. cosa che diciamo è di base per i medici, per i futuri medici e per tutti coloro che si occupano delle professioni sanitarie, e che in questa foto viene rappresentata in maniera allegra, ma che è un argomento di base per tutti coloro che si occupano di questa professione. Quindi grazie alla dottoressa Laurenti. Il secondo posto invece è per la dottoressa Laura Spina, spero, eccola qui. Allora, la dottoressa Laura Spina, il titolo è Comportamenti relazionali disfunzionali, il ghosting. Allora, parliamo di salute mentale. Il ghosting che cosa è? Praticamente diventare un fantasma per qualcuno. Cioè una persona che noi conosciamo improvvisamente ci abbandona, non si fa più trovare, non si fa più sentire. Beh, è sempre successo, no? Ognuno di noi nella propria vita ha qualcuno che improvvisamente è andato via e non si è più visto. Ma nell'epoca di oggi della comunicazione globale è una cosa che colpisce particolarmente. E chi è oggetto di ghosting, che cosa prova? Prova ansia, depressione, stress. Si domanda il perché sono diventato un fantasma per questa persona senza avere una risposta. E questa foto rappresenta benissimo il senso del diventare invisibile agli altri. Quindi io ringrazio la dottoressa Spina per un argomento molto interessante. Invece il primo posto è dato dalla dottoressa Annalisa Canta con la sua foto Risuonando. Allora, se vedete la foto è molto molto suggestiva e allora in questo caso andiamo nel campo della ricerca e innovazione. Perché? Che cosa è questo apparecchio? È un apparecchio di risonanza magnetica di ultima generazione che noi abbiamo nello stabulario in U8. Quindi in effetti lei è riuscita a creare questa immagine quasi magica, no? In effetti. Questo alone, questa è veramente un'immagine magica, ma che cosa ci dice? Che noi non siamo fermi nella ricerca, che continuamente andiamo avanti e vogliamo ottenere sempre di più. Quindi ricerca e innovazione, salute mentale e cura degli altri. 3 argomenti fondamentali per Bicocca per la salute. Quindi io vi ringrazio tutti quanti, ringrazio i partecipanti e ringrazio voi per la pazienza avuta e ringrazio i miei collaboratori. Ma il mio premio, devo essere sincera, sono le foto. È il mio come? Ma io, allora, loro lo sanno tutti quanti, io amo la fotografia in una maniera incredibile, perché per me è come un'immagine per l'eternità, ed è così. E veramente io devo ringraziare tutti quanti loro. E, grazie, solo questo. Grazie.
No, quindi la mattinata è andata molto bene, è conclusa, adesso abbiamo il lunch, il break, ci ritroviamo alle 2 con i saluti e l'introduzione anche della rettrice e poi il programma che conoscete. Buon pranzo.